there are PowerPoints on the M drive, as well as video, as well as recorded lectures on my YouTube channel regarding larynx. I know this gets challenging, so there are multiple resources out there. In the event that anybody wants to also look at those. We'll go over, we'll re-review the anatomy. I know we started a little bit last time. And we will go over sort of how to open it up, what to look for, staging, etc. Just giving the larynx a little rinse, a little bath. You grab a knife. Thank you. Heather, I assume you'll monitor whatever chats may pop up, but please also feel free to just speak up because I think your voice is also heard, yeah? Okay, all right. Thanks for coming. No problem. Okay. So if you guys remember from last time, we basically have the tongue up front, which we removed, but we still retain the two valleculae on either side with the sort of midline raphe. We have the lingual surface of the epiglottis here. As we round the corner, we have the laryngeal surface of the epiglottis. If you remember, we have this opening here where we cut the pharyngeal wall from in the patient and carried down to the esophagus. So we opened up the posterior pharyngeal wall and the upper esophagus, assuming that the lower border of the cricoid / C6 vertebra is approximately where the pharynx ends and the esophagus begins. And you can kind of see the difference in caliber, right? Even there. Okay. Who remembers the name of the space that we enter first right here? It may be pear-shaped. It's called the, somebody may have said it. Piriform sinus. Awesome. So the piriform sinus is where your boluses of food go as they travel down. Awesome. Okay, if you remember, I think we also said this last time, but we have some cartilages that are in here. These two little guys that kind of stick up right there and right there are the aretinoids. They also are accompanied by the corniculate and cuneiform, but those are super, super tiny, so we don't really talk about those. And then this fold, of course, between the aretinoid and the epiglottis is the aryepiglottic fold, right? There's one on either side. And so depending on where the surgeon cuts the pharyngeal mucosa to enter and to remove the larynx, your mucosal margin in your posterior side of your larynx may be very tight up here on the AE fold. It may be very wide on the piriform sinus. It may or may not cover the cricoid cartilage, right, which is sitting back here. If you recall, the cricoid cartilage is the only complete ring in the larynx. So the thyroid, right, is basically a shield in front. The cricoid is a complete ring where the posterior horn is much thicker than the, the posterior lamina is much thicker than the anterior lamina. And then the tracheal rings are C-shaped also, sort of similar to the thyroid cartilage, although the thyroid cartilage is of course much bigger. The tracheal rings are much smaller, and in the back, they proceed to be just a membrane, right? So they end, you can see me dipping in the membrane. So right, C-shaped, open in the back. Okay, cool. You can also see, yes, we discussed this last time, the hyoid bone. right? So the hyoid bone is also sort of a C shape that sits here and attaches the extrinsic tongue muscles, which I'm pulling on, right, to the tongue, and suspends the larynx off of the tongue. So these rounded structures, which I'm sort of holding here, are the portions of the hyoid bone that I'm pulling on, and you can see perhaps as they move up and down. Okay, maybe I'll skim off some of that and we can maybe take a better look at the hyoid. Who's got comments right now or questions? And from you guys, like, what are the most challenging things when you see a larynx? Like, what is a challenge to you? What poses a challenge? Is it the anatomy? Is it how to cut it? Is it everything? No comment. It's everything. Okay. All right. Okay. Okay. So we've freed up a little bit our hyoid bone. You can now see there's sort of a cleft there where it moves. Okay. Our strap muscles here are in the front, which usually do come with the larynx. For ease of seeing what's going on, we're going to sort of skim off the strap muscles. So those generally end up being your surgical resection margin on the anterior plane. But I want us to see the thyroid cartilage. So we're just going to clear it up a little. What structure in the neck do we tend to see that is the thyroid cartilage, even in a real living, breathing person? Colloquially, what do we see of the thyroid cartilage? Adam's apple. Yeah. So that protuberance right there, right, is essentially what we refer to as the Adam's apple. And so that's where your vocal cords internally will attach to. Sorry, if you guys want to come around, or I don't know if there's any better way I can do this. Please, don't be shy. So yeah, so when we go inside, the vocal cords are basically going to attach internally to essentially there. That's the longest part of the larynx. And there's the muscle in there that allows it to expand and contract to change the pitch of the voice. Okay. The thyroid cartilage interacts here with the cricoid cartilage, and then, which is basically here. And then we have the tracheal rings. So if you all remember, when you were trying to save lives as a medical student, and they were talking about, cricothyrotomies or whatever. And so you'd put your straw in the membrane between the cricoid and the thyroid cartilage. So you can essentially feel that divot right here. And so that's that area between the cricoid and the thyroid. Okay. What else can I tell you about the external surfaces? So tumors, when they arise, I cut through the piriform here a little bit, sorry. Tumors can arise mostly within the lumen of the larynx, can also arise in the anterior pharyngeal wall, which would be this postcricoid mucosa, or in the lateral or posterior pharyngeal walls. In that case, the specimens are essentially laryngopharyngectomies, where they cut, I'm going to pretend we have one now, where they cut they cut anatomically in the patient at the level of the esophagus, right? So you're probably not going to get, thank you, an esophagus, but you may get an intact pharyngeal wall like this with your few. Usually they only take off a couple tracheal rings, not as much as we have. And then the tumor is going to be somewhere in the food space, right, rather than the air space. So remember, there are essentially usually two different spaces in which the tumors can occur, in the food space of the pharynx or in the air space of the larynx. Less commonly, we see them in the pharynx, but you may see a laryngopharyngectomy in your time here. In this case, the tumor would be in this space, okay? And so what we would normally do, I know we cut through the posterior midline here for this case, but what we would normally do is sort of determine on which side the pharyngeal tumor is more prominent. Is it more prominent on the left or on the right, or is it flat in the midline? Usually it's a little bit one side or the other, but regardless, we're not going to usually cut through the posterior midline like this. Usually we're going to cut through whatever side is going to be farthest away from the tumor. So if your tumor is slightly, perhaps on this patient's right, you would make your initial cut all the way over here on the left, and then the flap would open this way. Or if it were a predominantly left-sided tumor, you'd make your cut on the right. Let me just do it here since we have the halfway cut anyway, right? You'd make your cut here on the right, and you'd open up, right? You'd open this, would be intact. You'd open up this flap, and then you would have a posterior pharyngeal wall flap, if that makes sense, right? So I'm imagining that these two are still intact. We've cut on the right side, we've opened it, and then our tumor is somewhere in here. In these cases, if the tumor is very nicely organized in the posterior pharyngeal wall, you can then also proceed to cut here and turn this little flap into its own separate specimen, which we essentially treat like a skin ellipse or a mucosal ellipse. And so if you think about it, where in this case, the surgeon would have cut here on the inferior portion, right? The surgeon would have cut here on the superior portion, but these two lateral cuts are ours, are the pathologist's cuts. So once you remove this flap, the cut here is no longer a margin. Yes, it's only this inferior edge and this superior edge. Does that make sense? Okay. So that's generally how we handle posterior pharyngeal wall tumors. Questions, comments? Okay. Let's now open and see how we usually more often get them. So I'm actually going to maybe remove some of this mucosa because usually we don't always see all of this stuff. So usually the mucosa of the posterior pharyngeal, or excuse me, the anterior pharyngeal wall has been already cut off by the surgeon. So I'm going to pretend that that's what's going on. It's kind of fun to do it step by step because then you could go through every single like permutation. Okay. All right. So usually, let's get rid of this wall. Okay. Usually, I'm just going to leave this up here in case we want to have a pretend posterior pharyngeal wall specimen again. Okay. Actually, it was this way. Whatever. Don't remember. Okay. All right. So usually this is more like what we see for a laryngectomy where the tumor is in the mucosa. You see this sort of midline pale area with these two muscular beds on either side of it, right? Those are your oblique, transverse, etc., cricoarytenoid muscles. So that and that. When we talk about the spaces, let me peel some of this off. When we talk about the spaces of the larynx, one of the spaces is the so-called post-cricoid space, which is basically we're in it right here. So we're in the space, the potential space behind the cricoid cartilage that contains this musculature. And so that is a noted space for tumor staging because most tumors are anterior and or lateral, but some creep around to the posterior side. And once they start to invade posteriorly through the cricoid cartilage and enter the post-cricoid space, that's another staging parameter that we want to look out for, okay? Okay, but in this case, we have now our mucosa that no longer covers this. We have mucosa still in the sort of piriform sinus and this edge here. And so again, depending on where the surgeon cut the mucosa, we're going to be dealing with this very tortuous circle of mucosa around the top side of the larynx, okay? The bottom side of the airway is very simple. It's usually just the tracheal ring, but the top side is the complicated one, right? So let's sort of start simply on the anterior portion. You want to pick a piece of mucosa that you can see and follow it around the entire circle. So you see this mucosa here in the vallecula on either side of the epiglottis. So that's your epiglottic margin. You kind of follow this around and around and around. In this case, in the piriform sinus. Yeah, you follow it around in the piriform sinus. Sorry, I'm going to loop around. Keep following it. And now here you wrap around to this line right here, which is essentially right below the arytenoids and right above the cricoid. Keep following it around. It's in the piriform sinus again. Follow it around, follow it around, follow it around, follow it around in your back. So when you ever get a larynx and you want to identify all of your superior mucosal margins, you have to walk around it like that. And as I said, depending on where the surgeon cuts, the mucosa may or may not be farther out or closer in. It's kind of hard to get this mucosa off, but the names of those margins are going to differ depending on how narrow or wide they are. So I know the standard, right, the classic margin is the aryepiglottic fold margin, where they actually cut the mucosa very tightly, like right up here, right? And so that really is the AE fold margin. But in some cases, right, it's way out here in the piriform sinus, okay? Some cases it's right, you know, between the arytenoids and cricoids. In some cases, it's way farther down and covers the cricoid. So again, that terminology, don't forget that terminology is non-standard. It will change depending on how the surgeon makes the cut. Okay. The other thing we start to see as we've exposed more tissue are the horns of the thyroid cartilage. So you may be able to see, I'm gonna get rid of some of this juice here. Yeah, oh, that's good. So you may be able to see the portion of the hyoid here that we already saw before. If you don't believe me, just move it around. All right, there's the hyoid. You can see that in this bundle of tissue, though, there are two things. There's the movable hyoid, and there's this other little tip, right, that doesn't move. All right, so the tip that I'm moving are the tips of the hyoid, but this other tip that's not moving, does anybody know what that is? This little ball right there. So the arytenoids are in here still. Yes, this is the superior horn of the thyroid cartilage. So the thyroid cartilage, which is generally a shield in the front, right, sends off two superior horns above and sends off, I can't do it with my pinkies, two inferior horns below, okay? So the superior horn of the thyroid cartilage articulates with the hyoid, as you can see here, and even on this side, right, okay? Yeah, it doesn't work if you don't make the noise, exactly. So I'm going to get rid of some more of this muscle and expose a little more of the thyroid cartilage. Here's your nice muscles on the anterior surface. Sorry guys, we're going to get rid of those. Okay, and then so right here, right, superior horn, thyroid part, what I'm holding here is just soft tissue, right? So that's not cartilage. So superior horn, thyroid cartilage. And then if you can imagine, maybe I'll dig it out. The thyroid, if you guys that are here, if you want to touch it, put on some gloves so you can sort of feel what I'm saying. Yeah, there we go. That's exposing a little bit more. See, we can't really do this with the larynx. We have to keep all those margins. Okay, so this, I can feel the space here. This is where the thyroid cartilage begins and ends, superior horn, and then you can feel it better than you can see it, but there's an inferior horn, yep, that comes here and articulates with this ring, right, which is the cricoid. So I'm going to have you guys maybe feel. So this side of the thyroid cartilage is exposed. You have the superior horn here. You have the inferior horn. You can feel it more than you can see it. Again, as I said, maybe I'll dig it out just a little bit more. All right. And then I apologize. I cut off a little bit of the thyroid. Excuse me. I cut off a little bit of the cricoid cartilage right there. But right here, right, that's your cricothyroid membrane. So you can actually feel where the cricoid and the thyroid begin and end. Let me get this knife away from you guys. Anybody out there in the virtual world have questions? Cool. Cool. Did you guys all feel those things? All right. So those things are, of course, on both sides, right? But we're gonna leave this side a little bit more intact. Okay. So just as a reminder, now that we've all felt it, I'm gonna stick my knife in there, right? So that you believe me, that really is between the thyroid and the cricoid cartilage. Between the cricoid, below it, right, we have the trachea. So thyroid cartilage, space, cricoid cartilage, space, trachea. Awesome. So those of you who felt it, you felt the inferior horn of the thyroid cartilage articulate with the cricoid cartilage, the superior horn articulate with the hyoid, and that will repeat on the other side, right? There's your Adam's apple. Okay, great. Cool. All right. So those are the external anatomies. Again, we took the thyroid gland off last time, but remember, sometimes that sits here. We just unlike I'm doing today and last time, right? Don't remove all this stuff when we have a cancer case. These are all anatomic relationships and margins. So we don't remove any of that stuff. We just leave it all in. Sometimes I'll allow you guys to remove the hyoid if the tumor is far away from it, because it just provides another barrier to cutting. So we'll do that. We'll do that once we open it. All right. So now that you have all your anatomic landmarks and we've evaluated our mucosal margins, I just want to briefly demonstrate how to take the mucosal margins, because sometimes it's challenging for people. So when we're taking our mucosal margins, we don't want to get really any extra like tissue. We literally just want to get 2 millimeter strip of mucosa without like digging in to the paralaryngeal tissues. And so generally what I do is just sort of take a forceps and a tiny little scissor and just cut the 2 millimeter strip of mucosa off. Literally, that's it. That's your mucosal margin. And then you'll put that down, you know, as best as you can on FOSS. You know, at this point, if there's a positive here, like, let's just consider it positive, regardless of which side of the tissue you're on. So I'm generally not too concerned, but that's it. Those are the tiny little strips you want to get. You want to follow those strips around. Let's say here we're in the piriform sinus. I want to do the same here, just the little strip of mucosa. The reason is I've had you know, people who don't do this technique, and they like cut off a big chunk here, and then they end up getting, for example, pieces of invasive carcinoma that have invaded outward into these tissues, but isn't representative of true mucosal margin, because you have all this redundant like skeletal muscle and stuff that really isn't a mucosal margin, right? So just be careful that you're not getting, you know, giant chunks like this. That's a little overkill. Okay. Okay. Same thing when we come around with the, you know, anterior epiglottis. This is usually one of the farthest margins, but same here, just a tiny little strip. Done. All right. I think I've made my point. All right. So once you get all of those margins, generally I like to take those fresh because they're nice and soft, but taking them fixed is also fine too. The other mucosal margin you're going to want to take pretty soon is the inferior tracheal ring. You basically just want to snip that and do that on FOSS. So again, your tracheal ring and all of your mucosals can definitely be on FOSS as long as the tumor is at a distance from it. However, you know, you are never going to do one of these alone. We will always give you guidance, but I'm just having you think through it so that, you know, when you're actually doing it, after we've given you guidance, you'll kind of have a better understanding. Sometimes if tumors are very, very close to certain mucosal spaces, we may do them perpendicularly, but on balance, most are taken as on FOSS. Okay. All right, so once you have those, we're going to cut through the posterior midline. Most laryngeal tumors, as I said, are sort of anteriorly directed. If you know that it's one side or the other, you can aim your cut on one side or the other, but more often than not, we just go right through posterior midline, through this nice thick, you can hear it, cricoid cartilage. A lot of times the cartilages in these larynxes are calcified because number one, the patients have developed these tumors because they're generally smokers. And number two, most laryngectomies are not done as primary surgical treatments unless it's in extremis. Most are done as quote unquote salvage for when the patient has had chemoradiation and failed and recurred. So there's been, you know, rays shot at this person's larynx. And so that also ends up helping to calcify it. So the fact that they're already toxins from smoking, drinking, the fact that they generally have chemoradiation, the fact that they're generally older, these are often quite calcified. All right, and so then we have our, you can still see our little aretinoids, our little balls of the little, I'll show you guys there, show you guys here, these little balls of aretinoids that we've cut right through in the middle. And often if it is calcified, we're gonna crack it. So we want to hear that crack because that's the only way we're gonna get inside and see anything in there. Woo. Okay, so as you all know, we generally, you know, prop open and photograph this stuff. And then section it after it's been fixed overnight. So let's go through the anatomy here and why we care. So, okay, we have now, we'll look at at least one side of this, but of course know that it's mirrored, right? So here we have the thick cricoid cartilage that we've cut through. Again, on the other side, the thick cricoid cartilage that we've cut through. There's a tiny little, you may see this very brown, soft piece there, very brown, soft piece there. Can you guys see this? Does anybody know what this very brown, soft nugget is right on top of the cricoid cartilage? Anybody in virtual land? So that is the thyroaretinoid or the vocalis muscle that runs along the vocal cord. That's the one that I was saying that helps you change the pitch of your voice. So I mention that here now because when you cut through this anatomic area, sometimes the actual cords are effaced by tumor. And if you can at least identify this muscle, you know you're at the level of the true cord. So let me maybe zoom in a little bit here. Does that make sense? So true cord muscle, right, correlates to the anatomic line of the true cord. Awesome. Cool. So if you remember the as I'm now pointing to the false cord. Great. So I apologize for that. The false cord is actually the one that's on top. The true cord is actually the one that's on the bottom. But let's just argue that, you know, for simplicity's sake, this muscle is at least at the level of the quote unquote glottis. And we'll describe what the glottis is. So I apologize for my mispointing right there. But as we enter the larynx, right, the space here in the epiglottis is the vestibule, right? It's like, hey, welcome to the larynx. Come on in. The first structure that you encounter is going to be the false cord. Then in between the false and the true is the ventricle, and then the true. So vestibule, welcome, false cord, ventricle, true cord, false cord, true cord, vestibule, ventricle. Should I do it again? Okay. False cord, true cord. Oops, sorry. Vestibule, ventricle in between. Yeah? Yeah? Okay. The other thing that's nice about the true cord, at least in, you know, a normal site, is that there's also a band. There's this sort of fibrocartilaginous band, and it looks a little bit whiter. I think you guys can maybe certainly see that in person. I hope you can see it on the video, right? So you have the muscle to tell you that you're at the level of the glottis, and you have the band also to tell you that you're on the true cord. False, true, muscle. Okay, so when your glottis is effaced, that muscle is helpful. Vocalis/thyroaretinoid. Okay. So what do we mean by glottis? Okay, so we talked about compartments of the larynx. So there's the supraglottis, right? The glottis, and the infraglottis. If you can identify the glottis, everything else falls in between. Does anybody in here or out there know how to identify the actual glottis? What are the anatomic landmarks? I don't know if your little red button is on. Does that mean we can't hear people? It should be showing. Okay. Okay. So the glottis begins in the ventricle, and goes to about 1 centimeter below the true chord. So if we have a ruler, we can measure that. So if you put your 0 point, right, if you put your 0 point in the ventricle, that's about oops, sorry, let me hold it up, maybe you can see it better. All right. About 1 centimeter below. Yeah, get in there. My fingers. Okay, cool. So that narrow area is the glottis, and that zone, right? Follow that zone circumferentially around. That's the glottis. Therefore, that means basically everything above, so the false chord and the epiglottis is the supraglottis, and then at that 1 centimeter point and below, that's the infraglottis, until you get to the inferior border of the cricoid, which we've nicely cut through, right? Then you start the trachea, then you are no longer in the larynx. So arguably your largest subsite here is the supraglottis, which is all of this. Your next two narrow subsites are the glottis at 1 centimeter, and then the infraglottis, again, maybe about another centimeter or so before you get to the trachea. Make sense? Again, why do we care? Staging. So each of those three subsites has a different staging system. By the time you get to T3, T4, they're like the same, but at the lower stages, it does matter. Okay, let's continue our cutting. Is there anything else to point out here? Okay. There's a frozen. Does that mean I'm doing it? Yeah, because I'm on frozen. Okay. Who's here? Me. All right, let me know when it's ready. All right, sorry, guys. Okay, so our next step is to generally cut through the anterior midline at the anterior commissure, right, which is where the chords join. So I am going to start that, not cut myself. All right, so anterior commissure, kind of calcified, epiglottis, anterior commissure. Now I'm reaching up at the top, hyoid bone and calcified thyroid cartilage. So generally, for me, the hammer is the way to go here. In this case, not a hammer, but all right, there we go. So as you can see, we've cut through essentially all of it, except for what we can't cut through, which is the hyoid. So we can striker through that and expose it, or for convenience sake, I can just shave it off. So if we together see a larynx in which we think that the hyoid bone is far from tumor, we can actually just skim it off, because as you can see, every single cut you're going to make, you're going to encounter that thing. It's everywhere. So for sake of simplicity, I'm just going to do that now. Just get rid of it. Is that okay with everyone? At least on one half. Cool. All right. We'll leave it on the other half, but we'll do it on this half. There we go. So now we've removed that obstacle. So it'll be easier to make our cuts. But we can nicely see what we've cut through on the anterior side, right? Which is we've cut through the epiglottis right here. We've cut through the thyroid cartilage, which in this case is quite thin and a little bit calcified right there. We've cut through this little tiny, oh, where is it? Oops, sorry, let me get rid of that. We've cut through, there it is. Actually, again, just like everything else, you can feel it better than you can see it. There seems to be a zone of demarcation right here. That little rim is the anterior lamina of cricoid, if you remember. Posterior lamina of cricoid is here. So posterior lamina, anterior lamina, got it? Everything above it, this is thyroid cartilage. This is epiglottis. Everything below it are tracheal rings. So you can see, and maybe you can remember histologically, that the cartilage of the epiglottis is different from the cartilages of the thyroid, the cricoid, the tracheal rings. What histologic type of cartilage is the epiglottis? Elastic, yep, it's super bendy, right? And it actually looks different. It looks quite chalky and white. And these guys, not really bendy at all, right? So these are hyaline, and they're often calcified, as you can see. Yeah. Okay. So now we'll talk a little bit more about the spaces. So I'm going to lay it this way. Okay. So the spaces are potential and real spaces where tumor can go. Again, important for staging. So subsites, supra, glottis, infra, and then spaces. So this fatty tissue in front of the epiglottis, right, is the pre-epiglottic space. If you remember where it came from, right, it came from this region below the valleculae, right, where the base of tongue would have started. Okay, so that is the pre-epiglottic space. That's important for anatomic subsite staging. The paraglottic space is basically a potential space between the true cord and the tracheal cartilage. As we make more cuts, we'll maybe more examine the paraglottic space, but it's more of a potential space between the true cords and the thyroid cartilage. Okay, and then the post-cricoid space, again, is a potential space posterior to the cricoid. So pre-epiglottic, paraglottic would be in there, and post-cricoid is back here. Okay, okay. Remember, there's your muscle. All right, so let's make our next cut. So then our next cuts are going to be essentially perpendicular as we can to the mucosa and parallel as we can to our prior cut. But it's sort of it's a clock, right? And so you might end up with sort of pie-shaped pieces because your mucosa is sort of smaller than your anterior tissues. Is it ready? Okay. So we're gonna, eventually it's not gonna be perfect parallel lines, but I'm gonna go do the frozen. Does anybody want to take over? Should we go do the frozen together? Hi. All right, guys, we're gonna wrap up quickly because we have a couple more frozens going. So, okay, our next cut, yes, was gonna be as parallel as we can to the prior and as perpendicular as we can to the mucosa. Something to this effect. Calcified again. All right. All right. All right. So we essentially would walk through the larynx in this manner, assuming that at some point we would have seen tumor. In this case, of course, we don't. Now I'm cutting through jaws. Excuse me, guys. All right. Super calcified. Very long, very long. Trachea. Crunch, crunch, crunch. Okay. Yes, that is generally how it's going to be. Okay, so let's look at this slice because this is kind of a nice one. So on both sides of this slice, so this is essentially what you're going to end up with, you know, generally with tumor being somewhere in there. All right, so you're going to have your epiglottis. Let me get my little pointer. You are going to have your thyroid cartilage. You're going to have your smaller cricoid cartilage. That's lovely. And then you're going to have your, in this case, a really long tail of trachea. Okay, but you can start to see your subsites and your spaces. So again, the fatty tissue anterior to the epiglottis right here is your pre-epiglottic space. Yes, the sort of potential space between your true cord and your thyroid cartilage is the paraglottic space. And then again, posterior to the cricoid cartilage, which we don't have because we're not in the posterior aspect, right? We have to come back over here. That's your post-cricoid space. Okay, so at least in this place, we have the pre-epiglottic space, the paraglottic space, we have the thyroid cartilage. So the inner or posterior lamina, and then the outer or anterior lamina is also important for staging because depending on basically how far, if our tumor is originating in the mucosa, right, and it's creeping out this way, that's how your staging is going to matter, right? So it's going to matter how far it goes into the paraglottic space Does it reach the inner lamina? Does it reach the outer lamina? And then finally, does it reach this stuff out here, which we know are the strap muscles? Yeah. If it's more up here, does it reach the pre-epiglottic space? So it's basically how far forward does it get? And this is why growth staging is actually quite good and quite better than microscopic staging, because you can see everything intact and make a good guesstimate as to what your stage is going to be just based on the growth. Excuse me. Carcinoma likes to take the path of least resistance. So yes, it can blow through cartilage, but it often tracks between the cartilaginous planes. So you'll often see it tracking between the thyroid cartilage and the cricoid cartilage through here to then blow out into the anterior strap muscles. That's not an uncommon finding. If you can see closely now, you do have more fatty tissue in the upper cord, right, which is the false cord. You do have more brownish muscular tissue in the lower cord, which is the true cord. So that's again confirmatory that your muscular tissue is your true cord, and your more fatty and glandular tissue is your false cord. Let's pull it up over here. Yeah, you can sort of see the same thing here. Your false cord, your ventricle, your true cord, which is much more brown and muscular, your thyroid cartilage, your cricoid cartilage. Yeah, okay. So when we end up sampling these, we'll generally end up blocking in sort of multiple slices, depending on where the tumor is and how far anteriorly it goes. But remember, you know, your important margins when you cut through, now you've got your mucosal margins already. Your important margins are going to be your anterior, you know, how far does the tumor go into your strap muscles? And then also don't forget that you still have this vallecula, basically fatty margin up here. So yes, we took the epiglottic mucosal margin, but often there's actually some a quote unquote soft tissue margin in the pre-epiglottic space that is going to be your ultimate superior margin of soft tissue. So sometimes when tumors encroach into the pre-epiglottic space, your close margins may also end up being the superior ones, as well as if they go anteriorly, the anterior ones, yeah? The last margin, which we have to be concerned about if the tumor starts to creep right now posteriorly, right? This was our cut here, right? So we're walking our way posteriorly. So just right of midline, second right of midline, keep going, keep going, keep going. This is the posterior space again. So once your tumor starts to encroach on that posterior, we have to be worried about that posterior margin as well. All these things make sense. So always remember that this isn't, you know, this isn't a flat plane. This is a tube that has a circle. And so we can designate our anterior, let me line these back up again. We can designate our anterior commissure, which we cut through already, 12 o'clock. And we can walk through, you know, 12, 1, 2, 3, 4, 5, 6, right? 6 would be here. And then when we go back to the other side, it would again be 6, 7, 8, 9, 10, 11, and then we meet back up at 12. So often if you want to sort of designate your slices as a clock face in that regard, that's also very helpful, because I know if you tell me, you know, I'm at 9 o'clock, I know you're basically right in this mid section between the anterior 12 and the posterior 6 on the left. Yes? So if you're the patient, right, I'm going to put this, even look at me. If you're the patient, right, your anterior midline is 12, your posterior midline is 6. And the cool thing about larynxes is that we generally gross them from the posterior side as if we are the patient. So it's actually a little bit easier, right? So 12, 1, 2, 3 is right, 4, 5, 6 is posterior, 7, 8, 9 is left, 10, 11, 12 is anterior. Cool? Cool. Okay. Do you guys in here or out there have other questions?
This is more just big picture, but
yeah.
How do they reconnect everything from the esophagus?
So That's an excellent question. They tend to put in, I believe at least initially some kind of trait because there's no there's no way. They can reconstruct with these Provox things, right? These sort of fake voice boxes. Now, I actually don't know how quickly they can do that, if they do that right away or if there's a delay. Those are very good questions, but it's certainly not a, it's a procedure that not a lot of places do and try to minimize because of the, because of the morbidity. Because it causes problems. But these people have ended up, I don't exactly know the tubing details. They can end up swallowing and eating. They can end up talking, potentially through grafts, slaps, voice boxes, etc. I would have to ask Blair, but yeah, that's all I know. So again, mostly these are done for salvage or salvage after chemoradiation for those reasons. Sometimes we get them because they've had cancer, they've had chemoradiation, they have tracheal stenosis, and they have malfunction of the musculature of that region, and they end up aspirating, getting aspiration pneumonia. And so it's actually safer for them to take out the stenotic non-functional larynx than to actually keep it in. So sometimes we get them where there's like just no tumor at all. It's just, so those are actually also good to practice on for grossing type of things. So yeah. What else? Okay, I think because we have a couple frozen, we're probably gonna pause. Take a look at the materials that are on the M Drive and on the YouTube. Always, 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 always call us. Always. Okay. Okay, thanks guys.